Ahmad, Sami, Ahmed. Dr. Muhammad, please proceed.
Good evening, ladies and gentlemen. Now we will have Rosh Symposium titled Meet the Expert with Breast Cancer and Ovarian Cancer. And our expert today will be Professor Muhammad Sabri Al-Qadi, Professor of Clinical Oncology at Ain Shams University. And our other expert will be Professor Rami Ghali, Professor of Clinical Oncology at Ain Shams University. And Professor Muhammad Sabri Al-Qadi will present the latest updates in breast cancer, and Professor Rami Ghali will present the latest updates in ovarian cancer. And I would like to start this session with my dear colleague, Professor Muhammad Sabri Al-Qadi. Please, Muhammad Sabri, go ahead, please.
Bismillah ar-Rahman ar-Rahim. First of all, I want to thank the organizing committee for organizing first online Ain Shams International Clinical Oncology Conference. I want to thank also our dear colleagues attending this conference from outside Egypt and from Egypt, and also thank Roche Company for arranging this symposium about latest updates in HER2-positive early breast cancer treatment. How big is the breast cancer problem in Egypt? Do you have higher incidence than worldwide figures? Breast cancer incidence is almost close to world figures, but mortality of breast cancer in Egypt is 1.6 times more than world figures. I think more efforts should be given for curing patient is needed, especially for the patient with early breast cancer. Is the breast cancer a single type of malignancy? The answer is no. All of us are aware that there is a family of breast cancer malignancies according to hormonal and molecular subtypes. I'll speak today about HER2 overexpression breast cancer patients. 1 in 5 women diagnosed with early breast cancer will have HER2 positive disease, and most of them are younger than overall population. Many women still have children living at home and have ongoing work and family responsibilities. So the most important question in my presentation today, does PCR, pathological complete response, post and neoadjuvant setting correlate with improved PFS and overall survival? To answer this question, in 2014, the FDA partnered with German breast group by Cortazar to do a meta-analysis to include 12 international clinical trials with more than 9,000 patients. 61% of them were T2 and 46% was nodal positive. There were significant correlation between PCR improvement and improvement of DFS and overall survival in high-risk breast cancer patients for the patient with HER2 positive and triple-negative disease. So the association between PCR and better long-term outcome is strongest in high-risk patient disregarding the hormonal status, either hormonal positive or hormonal negative. So evolution of breast cancer treatment now we moved from in surgery, moved from mastectomy to breast conservation. We moved from axillary lymph node dissection to sentinel lymph node dissection. We moved from neoadjuvant treatment for inoperable patients to giving preoperative treatment or neoadjuvant treatment with the operable breast cancer patient at high risk of recurrence. We moved from giving anti-HER2 adjuvant or neoadjuvant by trastuzumab only to give anti-HER2 dual blockage, either adjuvant or neoadjuvant. We also moved from giving same anti-HER2 for all cases to change to TDM1 for patients with residual disease as in Castellan trial. So according to ASU guidelines, has recognized that the PCR are surrogate for long-term improvement of overall survival and disease survival for triple-negative disease and HER2-positive disease. So neoadjuvant treatment for intermediate and high-risk patients and for of HER2-positive and triple-negative no longer an option, but in an ethical obligation. In the neoadjuvant setting, what's about dual blockage by adding pertuzumab to trastuzumab in the neoadjuvant setting for HER2-positive, especially for the high-risk patient with a T more than 2 centimeters or node-positive disease in high-risk patients for early breast cancer. We have here 3 main trials of adding pertuzumab to trastuzumab. We have a NewSphere trial and Trafina trial and Benis trial. All of these trials are comparing dual blockage plus chemotherapy against chemotherapy plus trastuzumab only. We have here that's a NewSphere trial. They have 5 arms of treatment, and Trafina trial they have 3 arms of treatment comparing dual blockage plus chemotherapy versus trastuzumab plus chemotherapy. And Benis trial, we have here that's 2 arms. We are using actually FEC plus followed by Perjeta and Herceptin plus Docetaxel in the insurance, medical insurance in Egypt. I think all of these trials are concerning about benefit of dual blockage plus chemotherapy versus chemotherapy plus trastuzumab only. In NewSphere trial, adding of pertuzumab to trastuzumab doubles the progression, doubles the percentage complete response. And this is in this slide that's there is doubling of percentage complete response in the patient receiving dual blockage plus Docetaxel versus trastuzumab plus Docetaxel. In Trafina and Benis trial, almost 6 out of 10 patients achieving PCR. And this slide shows that there's a clinical benefit of achieving more PCR for the patient receiving dual blockage against trastuzumab only. So the guidelines recommendation for adding double dual blockage pertuzumab plus trastuzumab in the neoadjuvant setting, their recommendation by NCCN guidelines category 2A, and 98% of consensus in St. Gallen, and also recommended by ESMO guidelines and NICE guidelines. If node-positive high-risk patient receives dual blockage plus chemotherapy only in the neoadjuvant setting and achieving PCR, is this enough? The answer is no. So in NewSphere trial, at 5 years, 14% of patients had relapsed or died.
Slides, we can't see the slides.
Even after 5 years of follow-up. So pertuzumab included in the adjuvant setting for the breast cancer patient. Pertuzumab in adjuvant setting treatment recommendation in the guidelines for high-risk patients, especially for the patient initially presented with nodal positive disease. It's highlighted in the guidelines by NCCN guidelines category 2A, and also St. Gallen, 90% of them are consensus with adding pertuzumab for the patient with initially positive lymph nodes. And patient also ESMO guidelines is level 1A recommendation, and also for NICE recommendation, it's recommended to add pertuzumab to in the adjuvant setting plus trastuzumab, and also in the ASCO recommendations. What's the Affinity trial? This is a trial, a phase 3 trials adding adjuvant study investigating dual blockage plus chemotherapy versus chemotherapy plus Herceptin alone. This is the trial design. They enrolled about 4,800 patients randomized between to receive chemotherapy plus dual blockage versus chemotherapy plus trastuzumab only. The new affinity updates descriptive analysis confirmed the benefit of Perjeta plus Herceptin in all node-positive patients, with 28 reduction in risk of recurrence associated with an absolute difference of 4.5% of invasive disease-free survival percentage. We can see here that there is over 6 years, there is 4.5% of benefit of adding dual blockage in the adjuvant setting against trastuzumab only. Is dual blockage in adjuvant setting in all patients is enough? The answer is no. Patients with residual disease need more care. So what's next in newcomer in the horizon? In Catherine trial, TDM1 was introduced an adjuvant treatment for patients with breast cancer. They designed to do more patients with residual invasive disease to receive trastuzumab an adjuvant setting versus TDM1 in the adjuvant setting. We enrolled about 1,400 patients receiving either Herceptin alone plus chemotherapy in the adjuvant setting or dual blockage plus chemotherapy, and they randomized one-to-one randomization to receive either Kadcyla, TDM1 as an adjuvant treatment versus Herceptin alone. The primary endpoint was disease-free survival. So adjuvant TDM1 cuts the risk of disease recurrence of death by 50% compared to adjuvant Herceptin in 3 years follow-up. Adjuvant TDM1 shows invasive disease survival benefit versus Herceptin in patients with residual disease after neoadjuvant anti-HER2 treatment, either with Herceptin alone or dual blockage. So we can see here that a patient receiving TDM1 achieving a benefit of 11.8% for the patient receiving Herceptin only in the neoadjuvant setting, and also comparable results with patients with receiving Kadcyla after Perjeta Herceptin in the neoadjuvant setting. So there is absolute improvement in Kadcyla versus Herceptin, either patient receiving dual blockage or single blockage before surgery. So in guidelines, there's updates between 2018 and 2020. There is almost updates about this allowed to modifications for adding adjuvant regimen among patients with HER2-positive disease and triple negative with residual disease. I think residual disease is now a surrogate endpoint to add additional treatment rather than adjuvant treatment or not concerning anti-HER2 family. To conclude my speech today, when to escalate or to maintain or de-escalate anti-HER2 treatment. For a patient with a node-positive disease going for surgery, you should go for a dual blockage Perjeta plus Herceptin, Perjeta plus trastuzumab to 1 year for 1 year. For patients with more than T2, 2 centimeters or node-positive disease, you should go for a neoadjuvant treatment as Terafina and Lucifer and Penis trial to add dual blockage Perjeta plus Herceptin in a regimen for 4 to 8 cycles before surgery. And for patients who achieved near PCR, you can go for either Herceptin alone or dual blockage. And patients with residual disease after neoadjuvant treatment, you should go for a TDM1 for 14 cycles as an adjuvant treatment. To conclude my take-home message, pathological complete response was announced to a surrogate endpoint for a better long-term outcome in breast cancer by FDA and after Cortazar meta-analysis in 2014. According to Lucifer and Terafina and trials, pertuzumab is recommended by international guidelines in neoadjuvant to achieve PCR rates 6 out of 10 patients. Also, according to affinity trial, initially nodal positive at high-risk patients achieving PCR are still at risk of recurrence. Therefore, guidelines recommended to complete dual blockage in adjuvant setting for 1 year for these patients. Patients who still have residual disease after neoadjuvant treatment, either with single or dual anti-HER2 blockage in neoadjuvant setting, are at a risk of recurrence. So escalation of concept of adjuvant treatment to DM1 for this patient proved to increase the disease survival by 50% in 3 years of follow-up, Herceptin versus Herceptin based in Catherine trial. Thank you for your attendance, and thank you. And I want also to thank my dear colleagues in Roche for arranging this very scientific meeting about this very important aspect in breast cancer. Thank you.
Thank you, Professor Mohammed Sabri Al-Qadi, for your elegant presentation. And I think we'll move to Professor Rami Ghali to give his talk on the updates in cancer ovary. And then we can have a Q&A for both of my dear professors, Mohammed Sabri and Rami Ghali. Please, Professor Rami Ghali.
Good evening, everybody. It's my honor to be present among all of you today. Thank you for the organizing committee. Thank you, Roche, for this nice opportunity. Thank you, Mr. Chairperson. Recent advances in first-line management of advanced ovarian cancer. As you all know, ovarian cancer is the 7th most common cancer in women. It accounts for 70% of those patients are diagnosed as stage 3 and 4, and 20% of them have metastasis at diagnosis. We know we have a lot of molecular players in several malignancy, as the breast, as the lung. Also, we have molecular players in the ovarian cancer. We have the BRCA, we have the TP53, we have the KRAS, we have the BRAF, we have the PTEN in different tumor subtypes, as we see. And also, we know that VEGF overexpression appears to be a key role player among all histologists. Regarding the primary management of ovarian cancer, the primary management is an upfront laparotomy. It's a surgical technique most often used, either upfront or interval, which is a total abdominal hysterectomy, bilateral salpingio-oophorectomy with examination of peritoneal surface, infracolic omentectomy, pelvic and para-aortic lymph node biopsy, and dissection if they're positive regarding the pelvic nodes. And we have to collect peritoneal wash for cytology. Our aim is tumor debulking and diagnosis. Also, we have a category of patients who desire fertility in 1A and 1C, where unilateral salpingio-oophorectomy can be done. Whenever we achieve an R0 resection with no residual, it's the best for us, and we see those are the PFS curves for the patient with 0 millimeter residual, for those of 1 centimeter or 10 millimeter residual, and those for more than 1 centimeter, those curves are beautifully separated. So women with any residual disease have poor progression-free survival, and also they have poor overall survival. Those are the curves of overall survival, where the hazard ratio is 2.7 for the patient who have from 1 to 10 millimeter of residual versus the patient who are R0 or there is no residual disease. So women with any residual disease have a poor survival and a poor progression-free survival. What are the timing of cytoreductive surgery? The patient should receive primary debulking surgery followed by chemotherapy, but we have a category of patients who would receive neoadjuvant chemotherapy, cycle of platinum-based chemotherapy, followed by interval debulking surgery for those patients with low albumin at presentation, poor performance status for surgery upfront, and the extensive tumor dissemination. Second, interval debulking surgery after primary surgery, suboptimal cytoreduction and 3 cycles of chemotherapy is controversy. There is an improved survival in the ORTC trial, but this survival was not confirmed in the GOG trial. We have several nomenclature in ovarian cancer, and what are the chemotherapy regimens used? We have the term platinum refractory when there is a progression during therapy or within 4 weeks of last dose of chemotherapy. Progression on chemotherapy, the patient is platinum refractory. We have the platinum resistant, those patients who progress, but within the 6 months of last chemotherapy dose. For those patients, the single agent chemotherapy, not a platinum doublet, we have to introduce either paclitaxel, topotecan, Calyx, or gemcitabine. The platinum-sensitive patients are those patients who present with a late relapse after 6 months, and especially after 1 year of the last dose, where also we give a platinum doublet is the treatment of choice. Regarding VEGF and angiogenesis on ovarian cancer, we know that the VEGF is the key mediator for tumor angiogenesis. It is associated with promotion of angiogenesis in early ovarian cancer, and VEGF expression is associated with ascites accumulation and poor survival. As we know, the VEGF enhance vessel permeability, including permeability to peritoneal vessels, leading to ascites. This is the mechanism of ascites development in ovarian cancer with the VEGF expression. Also, ascites accumulation associated with progression and clinically high level of VEGF expression and tumor angiogenesis in ovarian cancer correlates with a poor survival. As we see in this trial, those are the patients, the curve survival for the patient who does not, the patient who don't express VEGF, and those are the patients who express a VEGF. We see a big difference in survival between both of them with a statistically significant p-value. When the VEGF is expressed, there is a downregulation and downstreaming effect with stimulation of PI3K, PDK, AKT, leading to decreased apoptosis, increased survival, and thus enhancing angiogenesis and proliferation. And when using the BEVA, it reverses all these cascades. So the BEVA induce regression of existing tumor vasculature, inhibition of new vessel growth, and antipermeability of survival of surviving vasculature, which is consistent increased response rate, continuous control of tumor growth, and thus reduction of permeability, thus reduction of ascites and pleural effusion. Regarding the key trial in management of metastatic ovarian cancer with anti-angiogenic, we have the first line, we have the platinum sensitive, and we have the platinum resistant. For first line, the combination paclitaxel with BEVA is the ICON 7, GOG 218, and the ROSEA trial. For the platinum sensitive, we have with the platinum sensitive, that means the patient who progressed on platinum, but after 6 months to 1 year, we have the GOG with the platinum taxane doublet, or the Ocean trial with platinum gemcitabine. And for the platinum resistant, we have the Aurelia trial, which is the BEVA introduced with other chemotherapy rather than platinum doublet. It is the doxo single, liposomal doxorubicin, which is the calyx, paclitaxel, or topotecan. Our talk today will focus about first-line treatment in advanced ovarian cancer. So we'll start by the GOG 218 trial, which is a randomized double-blind phase 3 trial. It's a front-line management for epithelial, ovarian, primary peritoneal, or fallopian tube cancer with a stage 3, either optimal with a macroscopic residual, or stage 3 suboptimal residual, or stage 4 disease. So it is frontline for the high-risk patient or advanced stage patient. The stratification is based upon the performance status and the stages or the debulking status for those patients. We have 3 arms. We have the paclitaxel carboplatin, arm 1 with placebo. We have the paclitaxel carboplatin with BEVA and maintenance placebo. And we have the investigational arm, which is paclitaxel carboplatin with BEVA and then maintenance BEVA for 15 months. The characteristics are well balanced between both arms. As we see, there is a good separation of curves between the patient, and the benefit in PFS is seen for the patient who received paclitaxel carboplatin plus BEVA and then BEVA as a maintenance, with a median PFS of 14.7 months versus 10.6 months, a 4-month difference, with a hazard ratio of 0.7 and highly statistically significant power for the study. Regarding overall survival, we see that both curves are going together, are declining together, so there is no survival benefit in this GOG trial. But we see, when we see the median survival, when we separate the curve and we do subgroup analysis, we see, when we see the patient for stage 4 disease, we have a good separation of curve. When we see the median PFS is 40 months for the patient receiving BEVA plus maintenance and 32.9 months for the patient receiving BEVA without maintenance. Here, there is a statistical significance for stage 4 disease. The blue, the light blue one, when we see the hazard ratio is 0.7 with 40 months median PFS. So when doing a subgroup for stage 4, we can achieve a survival benefit. And also when doing an exploratory arm for the ascites, as we know, the ascites predict the population of women likely to derive long benefit for beva. We see that there is a PFS benefit and there is an OS benefit for those patients with ascites, where the hazard ratio is 0.7 for the PFS regarding patient with ascites, and the hazard ratio is 0.82 for the patient with ascites regarding overall survival. The adverse effects were manageable and were similar between both groups and similar to other beva trials, where we see that the grade 3 is mainly GIT events, hypertension, proteinuria. So the GOG 218 met its primary objective by increasing PFS in frontline treatment for advanced ovarian cancer when using Pacli, Carbo-Beva, and Beva as a maintenance for up to 15 months. And the side effects were really manageable between both groups. And we see that carboplatin paclitaxel Beva with Beva maintenance should be a standard of care in advanced ovarian cancer. Regarding overall survival, we did not achieve an overall survival for the whole population, but further assessment overall survival we could see difference, especially after long time follow-up, because we have a long PFS, and by doing some exploratory analysis regarding the stage 4 and the patient with ascites. And also, there is lack of control of our multiple subsequent line, because the patient who did not receive Beva as a second line, they received Beva as a second line. So this could attribute that we did not achieve, or the study did not achieve an overall survival benefit. When you go to the ICON 7, it's slightly similar, but with different study design, where it included also the stage 1 and 2 bad prognosis. We have the stage 3 and stage 4, but we have the stage 1 and 2A, the patient with grade 3 or the clear cell subtypes. Those patients included either primary debulking or secondary debulking. The stratification is based upon the stage and debulking status, the magnitude of the residual, timing of treatment start. As we have in this trial 2 arms, we have the Pacli Carbo and we have the Pacli Carbo Beva, but it's a different dose. It's 7.5 milligram per kg, not 50 milligram per kg every 3 weeks, but it is for 12 months. Baseline characteristic well balanced between both groups. And we see that continuation of Beva significantly increased PFS compared with chemotherapy alone, as we see. And we see as 3 months, 19.3 versus 16.9 a median PFS, with a hazard ratio of 0.86 and statistically significant value. Still no overall survival benefits. This is for the whole population. But in this trial, we defined another high-risk group. The high-risk group in this trial was the patient with stage 4 disease, either the patient who did surgery or did not do surgery, either the surgery led us to an optimal or suboptimal residual. So stage 4 per se is a high-risk group. And stage 3, those who did not do surgery is a high risk, or stage 3 who performed surgery and had a suboptimal residual more than 1 centimeter. Those are the high-risk group. So those in purple are our high-risk group. Any stage 4 or any stage 3 who did not underwent surgery or with a suboptimal residual, those are the high-risk group for ICON 7. And when doing analysis for the high-risk group, we see much more separation of curve, as we see the PFS 16 months versus 10.8 months. We are approaching now 6 months difference rather than 3 months, with a p-value statistically significant and the hazard ratio of 0.73. And when seeing the overall survival, we see here an overall survival benefit for the high-risk group. As we see, it's 39.7 months a median survival versus 30.2 months with a hazard ratio of 0.78, and here a good separation of curve. All grade adverse events were consistent with those reported with previous trial with Beva, as we see again, hypertension, bleeding, proteinuria. So the data from ICON 7 confirms the finding of GOG that frontline beva with chemotherapy, followed by single-agent bevacizumab, prolonged PFS in women with ovarian cancer. Bevacizumab treatment was generally associated with manageable side effects. When doing analysis for high-risk group in ICON 7, it supports the use of beva in women stage 3 and 4 ovarian cancer with any residual disease. So carboplatin paclitaxel plus beva with a continuation of single-agent beva should be the standard frontline treatment for advanced ovarian cancer. This was the conclusion also of the ICON 7 adding to GOG 218. Another trial is the ROSEA trial. The ROSEA trial, it included the high-risk patient and the patient with bad histology, ovarian, fallopian, or primary peritoneal cancer with maximally debulk. Prior also neoadjuvant chemotherapy were allowed. And also it includes the carcinosarcoma, which is a bad prognostic, a very bad prognostic group. It was a single arm. It is paclitaxel beva with concurrent beva and maintenance beva. But in this trial, the difference that it started to see, can we use prolonged beva rather than 15 cycle or rather than 15 months or 12 months of beva? Can we do it more than this, more than 12 months? Yes, they included beva as a maintenance for 24 months. And also, it looked at the patient with elderly patient because those are kind of patients that we see and we don't know, could we give for them beva or not? And we see that the median PFS with the patient over 70 and less than 70, it was similar. So there was no difference regarding age. Also regarding, interesting point regarding toxicity, less than 70 and more than 70, the toxicity was similar. So a median PFS of approximately 2 years is observed in patients regardless of age. Okay, regardless of age. Older age should not omit beva and should have the chance of taking beva, but we have to keep an eye regarding hypertension should be closely monitored. And thus our guideline is paclitaxel as a frontline based on ICON 7 and GOG 218, paclitaxel carboplatin with beva and beva maintenance, either 7.5 milligram per kg or 15 milligram per kg, all are acceptable, and it could be continued up to 22 cycles, or we can include more than this, 2 years, taking an eye on the ROSEA trial. Is it all? No, we have also the PARP inhibitor in the management of metastatic ovarian cancer. At the first line, we have the SOLO-1 and the PAOLA-1. For the platinum sensitive, we have the study 19 and the SOLO-2. And also we have data regarding platinum resistant, which was just presented lately. Our concern in the first line is the SOLO-1 and PAOLA-1. The SOLO-1 is a phase 3 trial of maintenance olaparib following platinum-based chemotherapy in newly diagnosed patients with advanced ovarian cancer with BRCA mutation. The study design including stage 3 and 4, high-grade serous or endometrioid, or ovarian, primary, peritoneal, or fallopian tube with a germline or somatic BRCA mutation. Cytoreductive surgery, either upfront or interval cytoreduction, is allowed. The arm is olaparib, an arm, and the placebo arm as a maintenance for patient advanced ovarian cancer BRCA mutant as a maintenance for the patient responded to primary chemotherapy. The study treatment continued until disease progression, and patient with no evidence of disease for 2 years stopped treatment, and patient with a partial response at 2 years could continue treatment. And the primary endpoint were PFS, PFS2, overall survival, and health quality of life. We see a beautifully separated curve where we see at 3 years a 60% PFS with olaparib versus 26.9% as for the placebo, with a good hazard ratio with 0.3. Also, a question coming to us. So could I use the olaparib, best to use it as a maintenance, or I will leave it for progression later on? We don't know if the patient progressed, will still be a platinum sensitive, so we can use it as being a platinum sensitive or not. But we have the PFS2 for the patient who received olaparib is still superior than the patient received placebo, despite some of the patients received placebo and upon progression they received olaparib. So olaparib is indicated as a maintenance for patient advanced ovarian cancer with somatic or germline mutation. As adverse effects are similar, despite anemia was higher, neutropenia was higher, and fatigue slightly higher. And then we go to the phase 3, PAULA-1, INGOT of 25, maintenance olaparib with bevacizumab in patients with newly diagnosed advanced ovarian cancer treated with platinum-based chemotherapy and bevacizumab as standard of care. A really interesting study. Now we have data that concurrent beva and maintenance beva, there is an adding value regarding PFS and regarding OS in some high-risk group. We have data about patients with BRCA mutant patient as a maintenance. We have a big PFS, either PFS1 and PFS2 for the patient receiving maintenance beva. So what about doing some puzzles? What about putting both together? Could we arrive at having something new or a new combo that can help our patient? But remember, when making a new combo, we need to see, is there a benefit? And what about the toxicity? So the PAULA-1 is an academic sponsored study in the phase 3 trial to evaluate the efficacy and safety of maintenance therapy with PARP inhibitors in patients with advanced ovarian cancer, regardless of BRCA mutation status, who are receiving first-line standard of care, including bevacizumab. So those are the stage 3 and 4 high-risk patients. At the first line, either doing surgery as either upfront or interval, with a platinum taxane chemotherapy plus bevacizumab, at least 3 cycles of bevacizumab, and the patient with no evidence of disease, either CR or PR. That means the responding patient were randomized to receive either maintenance olaparib beva versus placebo beva for 2 years. Okay, the primary endpoint is the PFS. Secondary endpoint PFS2, overall survival, safety and tolerability, and health-related quality of life. And the stratification is based here regarding BRCA status. The entire population, the aim of the study is to see the difference despite BRCA mutation, but the stratification is based upon either first-line treatment outcome and versus the BRCA mutation status. Regarding the intention to treat population, we see here that there is a PFS difference between the patient received the combo as a maintenance, the olaparib and beva versus beva alone, with a median PFS 22 months versus 16.6 months with a hazard ratio of 0.6. And when going deep to see our biomarker, we have that almost half of our population were HRD positive, and the other half were HRD negative or HRD unknown. The HRD positive include either BRCA mutant or BRCA non-mutant. So the HRD is the bigger family. Those are the HRD positive. HRD positive can include or can have a BRCA mutant subtype or a BRCA non-mutant subtype. So this is PFS by BRCA mutation status. Those are the patients with BRCA mutation, a very good separation of curve. We see a 1 year unpresentable data with 94% versus 76%, and the 2 year 76% versus 39% PFS. Regarding the non-BRCA mutant, still we have some separation, but the median PFS is 18.9 versus 16 only, and the hazard ratio of 0.7 compared to a 37.2 versus 21.7 PFS, as we see with a hazard ratio of 0.3. When we go by the HRD status, which is the test that we must be incorporated in ovarian cancer and must be sponsored later on, because I believe this is the most important test to do at the front when we have a case of advanced ovarian cancer. When we see those are the HRD positive, it's the best separation of curve for the patient with HRD positive, where we see a median PFS of 37 months versus 17 months. It's more than double. We still has a ratio of 0.33 with a very good separation of curves. And we see this is our median PFS. For the patient with HRD positive, by excluding the BRCA mutation or the patient with BRCA mutation, we see also still good separation of curve, where a median PFS of 28 months versus 16 months with a hazard ratio of 0.43. Still a PFS benefit, either patient with HRD positive with either BRCA mutant or BRCA non-mutant. But for the patient with HRD negative or the HRD unknown, we don't see this. We don't see this. Both curves are falling, taking hand in hand, and both are falling together down with no benefit or no hazard ratio advantage for each of the regimens. The adverse event when having two new drugs and two promising drugs, when putting them together, okay, there is a synergistic effect as we saw, but also the toxicity, we see that the toxicity is almost similar, but the anemia is higher as we see. The anemia is higher. The hypertension is not higher, which was strange for us, but the fatigue was higher, the anemia was higher. So our conclusion for the PAULA-1 INGOT of 25 trial, including frontline population of advanced ovarian cancer, which was not restricted by surgical outcome or BRCA mutation status. The study met its primary objective, demonstrating a statistically significant improvement in PFS in the intention to treat population when using olaparib bevacizumab versus beva alone. The pre-specified subgroup analysis shows that patients with tumor BRCA mutation and patients with a positive HRD status had the greatest PFS benefit. The result revealed a patient population beyond BRCA mutation patients, which are the HRD positive, that experience substantial benefit from maintenance treatment with our doublet olaparib and bevacizumab. The safety profile of olaparib in combination with beva was generally consistent with previous trial of each drug, and the addition of olaparib to beva did not impact its tolerability. And finally, our take-home message for today: the current standard of care for ovarian cancer treatment is platinum-based chemotherapy with beva and followed by beva for 1 year with either doses, either 7.5 or 15 milligram. For BRCA mutant patient in the first line, maintenance olaparib is the best treatment option for BRCA mutant. However, addition of olaparib to Avastin as maintenance shows significant improvement in PFS and could be considered another treatment option. For patient HRD positive and BRCA wild patient, those patients that we did not have any options before, we don't have olaparib. Addition of olaparib now to the standard maintenance beva is the best treatment option for them. Thank you so much, and we are waiting for all your questions.
Thank you, Professor Rami Ghali, for your elegant presentation. Unfortunately, we had a technical problem with the slides of Professor Mohammed Sabri Al-Qadi, and upon the request of most of the attendees, we have to repeat the presentation of Professor Mohammed Sabri Al-Qadi. So please, Professor Ashraf, can you repeat the slides of Professor Mohammed Sabri Al-Qadi, please?
Yes, sir.
Rahim. First of all, I want to thank the organizing committee for organizing first online Ain Shams International Clinical Oncology Conference. I want to thank also our dear colleagues attending this conference from outside Egypt and from Egypt, and also thank Roche Company for arranging this symposium about latest updates in HER2-positive breast cancer treatment. How big is the breast cancer problem in Egypt? Do you have higher incidence than worldwide figures? Breast cancer incidence is almost close to world figures, but mortality of breast cancer in Egypt is 1.6 times more than world figures. I think more efforts should be given for curing patients is needed, especially for the patient with early breast cancer. Is the breast cancer a single type of malignancy? The answer is no. All of us are aware that there is a family of breast cancer malignancies according to hormonal and molecular subtypes. I'll speak today about HER2 overexpression breast cancer patients. 1 in 5 women diagnosed with early breast cancer will have HER2 positive disease, and most of them are younger than overall population. Many women still have children living at home and have ongoing work and family responsibilities. So the most important question in my presentation today: does PCR, pathological complete response, post-neoadjuvant setting correlate with improved PFS and overall survival? To answer this question, in 2014, the FDA partnered with German breast group by Cortazar to do a meta-analysis to include 12 international clinical trials with more than 9,000 patients. 61% of them were T2 and 46% was nodal positive. There were significant correlation between PCR improvement and improvement of DFS and overall survival in high-risk breast cancer patients for the patient with HER2 positive and triple-negative disease. So the association between PCR and better long-term outcome is strongest in high-risk patient disregarding the hormonal status, either hormonal positive or hormonal negative. So evolution of breast cancer treatment now, we moved from in surgery, moved from mastectomy to breast conservation. We moved from axillary lymph node dissection to sentinel lymph node dissection. We moved from neoadjuvant treatment for inoperable patients to giving preoperative treatment or neoadjuvant treatment with the operable breast cancer patient at high risk of recurrence. We moved from giving anti-HER2 adjuvant or neoadjuvant by trastuzumab only to give anti-HER2 dual blockage, either adjuvant or neoadjuvant. We also moved from giving same anti-HER2 for all cases to change to TDM1 for patients with residual disease as in Castellan trial. So according to ASU guidelines, has recognized that PCR are surrogate for long-term improvement of overall survival and disease survival for triple-negative disease and HER2 positive disease. So neoadjuvant treatment for intermediate and high-risk patients and for of HER2 positive and triple-negative no longer an option but in an ethical obligation. In the neoadjuvant setting, what's about dual blockage by adding pertuzumab to trastuzumab in the neoadjuvant setting for HER2 positive, especially for the high-risk patient with a T more than 2 centimeters or node positive disease in high-risk patients for early breast cancer. We have here 3 main trials of adding pertuzumab to trastuzumab. We have a NewSphere trial and Trafina trial and Venice trial. All of these trials are comparing dual blockage plus chemotherapy against chemotherapy plus trastuzumab only. We have here that's a NewSphere trial. They have 5 arms of treatment, and Trafina trial they have 3 arms of treatment comparing dual blockage plus chemotherapy versus trastuzumab plus chemotherapy. And Venice trial we have here that's 2 arms. We are using actually FEC plus followed by Perjeta and Herceptin plus Docetaxel in the medical insurance in Egypt. I think all of these trials are concerning about benefit of dual blockage plus chemotherapy versus chemotherapy plus trastuzumab only. In NewSphere trial, adding of pertuzumab to trastuzumab doubles the progression, doubles the percentage complete response. And this is in this slide that's there is doubling of percentage complete response in the patient receiving dual blockage plus Docetaxel versus trastuzumab plus Docetaxel. So in Trafina and Venice trial, almost 6 out of 10 patients achieving PCR. And this slide shows that there's a clinical benefit of achieving more PCR for the patient receiving dual blockage against trastuzumab only. So the guidelines recommendation for adding double dual blockage pertuzumab plus trastuzumab in the neoadjuvant setting, their recommendation by NCCN guidelines category 2A, and 98% of consensus in St. Gallen, and also recommended by ESMO guidelines and NICE guidelines. If node positive high-risk patient receives dual blockage plus chemotherapy only in the neoadjuvant setting and achieving PCR, is this enough? The answer is no. So in NewSphere trial, at 5 years, 14% of patients had relapsed or died. The risk remain even after 5 years of follow-up. So pertuzumab included in the adjuvant setting for the breast cancer patient. Pertuzumab in adjuvant setting treatment recommendation in the guidelines for high-risk patients, especially for the patient initially presented with nodal positive disease. It's highlighted in the guidelines by NCCN guidelines category 2A, and also St. Gallen, 90% of them are consensus with adding pertuzumab for the patient with initially positive lymph nodes. And patient also ESMO guidelines is level 1A recommendation, and also for NICE recommendation, it's recommended to add pertuzumab to in the adjuvant setting plus trastuzumab, and also in the ASCO recommendations. What's the affinity trial? This is a trial, a phase 3 trials adding adjuvant study investigating dual blockage plus chemotherapy versus chemotherapy plus Herceptin alone. This is the trial design. They enrolled about 4,800 patients randomized between to receive chemotherapy plus dual blockage versus chemotherapy plus trastuzumab only. The new affinity updates descriptive analysis confirmed the benefit of Perjeta plus Herceptin in all node-positive patients, with 28 reduction in risk of recurrence associated with an absolute difference of 4.5% of invasive disease-free survival percentage. We can see here that there is over 6 years, there's 4.5% of benefit of adding dual blockage in the adjuvant setting against trastuzumab only. Is dual blockage in adjuvant setting in all patients is enough? The answer is no. A patient with residual disease need more care. So what's next in newcomer in the horizon? In Catherine trial, TDM1 was introduced an adjuvant treatment for patients with breast cancer in breast cancer. They designed to do more patients with residual invasive disease to receive trastuzumab and adjuvant setting versus TDM1 in the adjuvant setting. We enrolled about 1,400 patients receiving either Herceptin alone plus chemotherapy in the adjuvant setting or dual blockage plus chemotherapy, and they randomized one-to-one randomization to receive either Kadcyla, TDM1 as an adjuvant treatment versus Herceptin alone. The primary endpoint was disease-free survival. So adjuvant TDM1 cuts the risk of disease recurrence of death by 50% compared to adjuvant Herceptin in 3 years follow-up. Adjuvant TDM1 shows invasive disease survival benefit versus Herceptin in patients with residual disease after neoadjuvant anti-HER2 treatment, either with Herceptin alone or dual blockage. So we can see here that a patient receiving TDM1 achieving a benefit of 11.8% for the patient receiving Herceptin only in the neoadjuvant setting, and also comparable results with patients with receiving Kadcyla after Perjeta Herceptin in the neoadjuvant setting. So there is absolute improvement in Kadcyla versus Herceptin, either patient receiving dual blockage or single blockage before surgery. So in guidelines, there's updates between 2018 and 2020. There is almost updates about this allowed to modifications for adding adjuvant regimen among patients with HER2-positive disease and triple-negative with residual disease. I think residual disease is now a surrogate endpoint to add additional treatment rather than adjuvant treatment or not, concerning anti-HER2 family. To conclude my speech today, when to escalate or to maintain or de-escalate anti-HER2 treatment. For a patient with a node-positive disease going for surgery, you should go for dual blockage Perjeta plus Herceptin, pertuzumab plus trastuzumab to 1 year for 1 year. For patients with more than T2, 2 centimeters or node-positive disease, you should go for a neoadjuvant treatment as Terafina and Lucifer and Penis trial to add dual blockage Perjeta plus Herceptin in a regimen for 4 to 8 cycles before surgery. And for patients who achieved near PCR, you can go for either Herceptin alone or dual blockage. And patients with residual disease after neoadjuvant treatment, you should go for a TDM1 for 14 cycles as an adjuvant treatment. To conclude my take-home message, pathological complete response was announced to a surrogate endpoint for a better long-term outcome in breast cancer by FDA and after Cortazar meta-analysis in 2014. According to Nisphere and Trafina and trials, pertuzumab is recommended by international guidelines in neoadjuvant to achieve PCR rates 6 out of 10 patients. Also, according to Affinity trial, initially nodal positive at high-risk patients achieving PCR are still at risk of recurrence. Therefore, guidelines recommended to complete dual blockage in adjuvant setting for 1 year for these patients. Patients who still have residual disease after neoadjuvant treatment, either with single or dual anti-HER2 blockage in neoadjuvant setting, are at risk of recurrence. So, escalation of concept of adjuvant treatment to DM1 for this patient proved to increase the disease survival by 50% in 3 years of follow-up, Herceptin versus Herceptin based in Catherine trial. Thank you for your attendance, and thank you. And I want also to thank my dear colleagues in Roche for arranging this very scientific meeting about this very important aspect in breast cancer. Thank you.
Thank you, Professor Mohammed Sabri, for your elegant presentation. Thank you, Professor Rami Ghali, also for your elegant presentation. And now we will close the Roche Symposium, Meet the Experts, with Professor Mohammed Sabri and Professor Rami Ghali.